today's round speaker, Dr. Dhruv Joshi. Dr. Joshi is a trained pulmonary and critical care medicine physician and completed his fellowship at Cleveland Clinic. Um, Before that, he received his medical degree from St. John's Medical College in India and then internal medicine residency at MedStar Health. His career has spanned critical care practice and innovation across both India and US, where he has focused on improving patient outcomes in high acuity settings. And he is also a very well established entrepreneur. With that, Dr. Joshi brings a very unique perspective with his clinical expertise, entrepreneurship, and commitment to advancing care using artificial intelligence. Please join me in welcoming Dr. Joshi.
Thank you, Ankit. It's a pleasure to be here, and thank you for inviting me to be here at the Grand Round. So, very quickly, good afternoon, everyone. I'm a pulmonary critical care physician, and it's an honor to join you all here. Today, I'll be talking about when vision becomes vital and video AI at the heart of inpatient care. And my goal really is to share with you both the science and the possibilities of how vision, which is a fundamental human sense of ours, and and as a corollary to that, video can be harnessed through AI to reshape patient care. Right? So I'd like to start by, just a little bit more about my own background. And, I spent a large part of my career as a tele-intensivist, providing virtual critical care to a wide spectrum of hospitals. And did this from, large centers in the US to rural access centers. So have been part of a lot of telecritical care programs. And one of the things that I realized through my entire practice was that despite having all the data at my fingertips, from devices and from the EMR, which is what you use to typically provide telecritical care, what I realized was that every time I needed to make a critical decision, I found myself doing one thing first, which is turning on the camera, right? And just getting a glance of a patient was enormously helpful, right? Was a patient sitting up? Was the patient restless? Was the patient talking or coughing? Are they moving or not? Are they looking obtunded? What do they look like? And a single glance often told me more than, a lot of what I could see in terms of numbers on, the EMR or from the devices, right? And when you put all of these pieces together, I realized that the video is not just a convenience, but actually was a critical piece of information that was guiding decisions. And I think that's where we are sort of getting to a point where we're now beginning to treat video like a first-class data stream, right? And I think that is what has driven much of my work and is also the starting point for today's talk, right? So think about how we view patients, and we have monitors, we have pumps, we have labs, we have radiology, we have EMR data. Together, they create a repository of patient information, but there's something missing, and that's where real-time video and visual reality of the patient comes in, right? And adding video to the mix of all the other data that you have fills a blind spot and brings you closer to a true 360-degree view of what a patient looks like, right? So again, before sort of jumping in deeper into the science, I would sort of pose this question, if vision is a dominant human sense, then why don't we begin treating this like a continuous monitor, right? And I think that's the central question of this talk, and that's what I'm going to be spending most of my time in the next few minutes talking about, this particular aspect. Right. I'd like to to just bring up this paper that was authored by Neil Halpern and colleagues, and it's been a long time. This was authored in 2017, and this was a paper that essentially imagined what the ICU of 2050 would look like. And I think if you had read it in 2017, it perhaps would have seemed extremely futuristic and read like science fiction. But I think with every passing year, and I've read this paper several times now over the years, with every passing year, it seems less and less futuristic. Many of the building blocks of what the future ICU room would look like, completely autonomous, with ambient intelligence and AI, we're seeing the building blocks of those already here, right? We have sort of seen digitization, which happened with the entire wave of electronic medical records. And now we've sort of come to the age of AI, where we're seeing AI becoming more and more pervasive in our daily lives, and is also going to become more and more pervasive in the way that we provide care. And I think this is one of the central pieces of the ICU of the future, where you have video sensing, and so it's a fascinating read, and I would sort of encourage anyone who's interested in this topic to give it a read. Coming to the objectives of today, and before I go into the objectives, I'd like to make a disclosure. I am an entrepreneur. I'm a physician entrepreneur. I started a healthcare technology company called Cloud Physician, and I'm a director and a shareholder of Cloud Physician. So I'd like to make that disclosure here. Moving on to the objectives, what I'd like to achieve is to describe, the evolution of AI, and understand how video AI models function, identify real applications in the ICU and in inpatient care, evaluate their benefits for patient safety, staff efficiency, and learn what it takes to implement them responsibly. Right? So let's start by just understanding how the evolution of AI has happened, and it's moved rapidly and is moving increasingly rapidly in the current ecosystem. Initially, it was limited to structured data processing. This was pre-GPT, and then with GPT, we entered the era of natural language, where text became instructions, right? And I think that's been a game-changing development that's happened in the last 2 to 3 years. Now we're stepping into a new era where we have video language models, where, till now we've been dealing with large language models that have purely been text-based. Now we're adding in a vision or a video component to it, and entering an era of video language models where vision becomes central and reasoning engines begin to integrate multimodal data, which includes video. Right. So I think that's directionally where we are heading in this space. Uh, Again, just coming back to, machines have always been great at logic, and starting from calculators to spreadsheets to structured algorithms. Where machines have always struggled with has been subjectivity and perception, right? So pre-GPT, we had, we worked with text, we were great at logic and with heuristics. And then with the advent of GPT, then AI became conversational, and we've seen the dramatic effect it's had in our everyday lives. And the next part of AI where we are seeing it heading is where we're adding vision to it, and we're able to capture not just words, but actions, behaviors, and context across space and time, right? And so this is enabling us to get more insight into sensations, right? So once this is very exciting, and this is directionally where we're heading in the AI space. And so I'll talk a little bit about the work that's been done. So coming to what that's leading us to developing is video language models, which are like large language models, but you're giving them the power of video or of vision, right? So you're essentially adding sight to AI, and it can be very, very powerful and becomes far more clinically useful as well. Right. So again, once you are able to train these with domain specific video coming from inpatient rooms, from ICU rooms, you're able to interface them with what we already have in terms of LLMs. We're able to derive insights and become more autonomous in our functioning. Right. So, and when you add data coming from devices, data coming from EHR, and then you add visual data to it as well, it's becoming an increasingly comprehensive assessment of a patient. Again, very, very exciting times, I think, as we move in this space. So just to recap again, We began with text AI, evolved into language AI. Now we are in video language era, and we are moving towards reasoning engines where AI can integrate with multiple modalities, not just text, but video as well, and infer at a much deeper level, right? And again, I think that can be uh, very, very impactful in how we provide care to our patients, right? These can help us create very powerful tools in what is a very, very complex space. Provision of critical care, there's a lot of data, a lot happening, and our increased capacity to really, put all this data together is will make us far more effective as clinicians. So why video? Um, and 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 I think the reason is without again, if anyone who's practiced in a hospital will know, especially when you're taking care of critically ill patients, that without vision, you're flying blind, right? So EMRs are static, recording what has already happened. Patients are not static; they are dynamic. They are changing second by second. Video restores the spatial awareness. It adds real-time context, captures nuances, gives you the look of discomfort, the subtle restlessness. These are things that conventional data streams cannot show us. And as the saying goes, an image is worth 1,000 words, and a video is worth 1,000 images. So I think one of the things that I would like to really, if there's nothing else that you take away from this talk, just the fact that the video is a very, very rich medium, right? It has a lot of data in it, and far richer than words or numbers. Right? So uh, this was an article by Feifei Li, who's one of the foremost researchers. Dr. Lee's based in California, one of the foremost researchers in this space. And she and her colleagues described ambient intelligence illuminating dark spaces in healthcare. And they looked at the different ways in which you can get data outside of the conventional streams of data, which comes from devices or EMRs. They looked at cameras, they looked at depth sensors. So cameras were red, green, blue, color video, essentially using video cameras. They looked at sensors that looked at LiDAR, which measures distance to objects, and then they looked at infrared as well as a potential source of data, right? And they described how in a room in an ICU or an OR could be described, or data could be got from any one of these. Uh, I think the next paper that Dr. Fefeli and her colleagues authored on this topic is probably a seminal article, and will sort of form the basis for a lot more research that happens in this space. And this was a landmark study in NEJM AI, where the team analyzed 140,000 hours of footage from ICU rooms, and they analyzed this from 8 ICU rooms. This footage was then collected, was parsed through, was cleaned, and then was annotated initially by clinicians to give it clinical context, and then followed by annotators, trained annotators who annotated this footage. And on the basis of this annotated footage, trained models of AI were built. And eventually, these AI models were able to detect 40 actions that happen in ICUs and 55 objects that are in ICUs. And so when I say actions and objects, think of they were able to, once they were trained on this 140,000 hours of video, the AI model was able to detect when there was an X-ray room that, for example, an X-ray cart that was wheeled into the ICU. It was able to detect when a patient had an NG tube in place, had a Foley catheter in place, had a central line in place, was able to detect when a swab was used to clean the patient, was able to detect when the patient had a ventilator or an infusion pump at the bedside. And so 55 such objects were able to be detected. And this was trained to detect all of these objects. In addition to this, they were also able to detect actions. So, for example, was the patient moving or not? For example, if a procedure was being done, the video AI model was able to detect these 40 different actions. right? And so what that led to them was being able to continuously audit ICU care, right? Checking compliance with bundles, noting timestamps of interventions, all of these. So I think they're very, again, for anyone that's interested in this space, this paper would be a great reading, and I think this is going to set the basis for a lot more work in this space. Um, and I think this I'm going to now move on to showing how some of these things actually work, right? So once you have patient video feed coming in, the patient video feed comes in. There is the optionality for storage if you want to just store that video feed for review later. But now you can train models that will describe the scene, right? And that scene, once described, can lead to a certain action. That action could be an alert. For example, if you pick up some abnormality that's happening, a patient's breathing pattern is abnormal, and you want to send an alert to a rapid response team or to a nursing team or to a physician, you can send an alert. You can pend an order. For example, again, if a patient has been detected to have respiratory distress or increased work of breathing, and there is a certain protocol that needs to be followed on that basis, you can pend an order for an ABG or a chest X-ray or what have you. You can help with documentation, filling up with flow sheets. So if it is detected that a patient has undergone oral care, or every 2 hours, or a patient was turned at a certain time, or was in a supine position for a certain time, or if a patient in ARDS was prone for a certain number of hours in the day, to timestamp from what time to what time that patient was in prone position, that documentation can be pended, and you can do audits again, right, to determine how many times the central line was accessed. Was it accessed with gloves or was it not accessed with gloves? What was the time that a SBT, a spontaneous breathing trial, was started, and what time it commenced, at what time it concluded, and so on and so forth, including audits of potentially a code blue, how many people were present at a code blue, what time, and time stamping the different events that take place as a code blue progresses. I want to now move to showing you a video of how this actually works, right? So I want
with the
just
now
give
the
me
patient.
give me a second. So I here you see that this is an actor that's lying in the bed, right? And this is a trained actor who knows what they're doing. This is a video shot with this actor. And this actor is now you're able to detect that this patient does not, let's call this actor a patient, does not have a mask on, right? But when they put the mask on, the video AI is trained to detect that the mask is now on. And so this turns from red to green. So for example, if you have a patient who's on a BiPAP mask and the mask comes off or is taken off, this can automatically detect that the mask has been taken off. Now this actor is now going to mimic respiratory distress, increased work of breathing, right? So you'll see them heaving and use of abdominal muscles and chest heaving and use of accessory muscles of breathing. And you have the AI that is processing this in real time, right? So this processing is happening in real time. And as this processing is happening, you'll see that it is automatically able to detect that this patient is having increased work of breathing, right? So it takes about 20 seconds, and then you have a red alert that goes that this patient is going into respiratory distress. This is all automated. So this is an AI model that's picking up this work of breathing. This event is also recorded for later review, right? So you can go back in time. For example, if you come in the morning and you want to see what happened overnight at this particular time when a patient went into respiratory distress, that the AI is trained that every time you pick up an abnormality, you actually record that and you timestamp it. So you have a timeline view of what's happening, and you know at what time this event occurred and what happened at that time, and you can go back and review the video for for what happened at that time. You can go back and review several days or hours depending on how much video you want to store. Now you have the ability to add this to multimodal data. So you can get data from an EMR where you get radiology data, where you get data of your lab results and so on and so forth. And now sort of interface that or combine that with the fact that this patient is in respiratory distress, and sort of you can sort of see how this can enable a clinician to work much more efficiently and be able to get the data that they need in real time. And so, so that was a video of respiratory distress. I want to go on to showing you another video. Let me just right. So again, this is a trained actor. And in this particular video, this is a model that has been trained to detect emotion and movements on the patient's face, right? And using these movements and detecting this, pick up whether a patient is in pain or not. Right. So this requires, and I'll talk a little bit more about how this data is trained as we move forward on in this talk. But this is another use case that I wanted to show you where we're able to detect pain. Then another a model that can be used that has clinical applications is to pick up abnormal movements that a patient is having. You know, if a patient's restless, they're having abnormal movements that are not purposeful, and which unpurposeful movements that want to be picked up for signs of restlessness or delirium in a patient. Again, a model that can be trained to pick that up. Of course, you can add on more AI layers and make this a more agentic workflow, or add agents that will help you determine what the next course of action would be. And I'll spend some time on talking about that as well. Uh, this I want to spend a little bit of time just to show you this video, and this video is actually explainable AI. So I think it's very important that we understand that any AI model that we might use or evaluate, what exactly are we evaluating? And so this is a explainable AI video which actually heat maps the things that the AI has been trained to pick up on. So the first video that I had shown you was a video that picked up increased work of breathing, respiratory distress. So the AI model has been trained uh, to to look at these parts where you see the heat map is on, right? So it's looking at the chest, it's looking at the abdomen, it's looking at the movements of the chest and the abdomen to see, and has been trained to determine whether this is normal or abnormal, and validated, needs to be validated as well. Right. So this is what an explainable AI video looks like, which essentially does the same thing that you or I would as a clinician when I go into a room to assess a patient. I look at the patient and I want to see what the different parts of the patient that I would assess and I would look at. Those are the same things that the AI model is also looking at. This was a paper that looked at the detection of delirium. Again, I think this was a study. If you look at it, it was published in the American Journal of Respiratory Critical Care Medicine. And what they were looking at was they were looking at activity. Again, if you look at the heat maps here, and if you look at the bottom two images, there's day 6 of the recording and day 7 of the recording. So here you have a heat map that's picking up between 11 and 11:10 p.m. There is abnormal activity at nighttime that's happening. And again, the motion heat map that looks at the patient at 3:10 to 3:20 p.m., which is bang in the middle of the day, and there is complete inactivity there, right? So picking up hypoactive delirium in a patient that's been in the hospital for several days, has been intubated as well. Uh, I want to now come and talk a little bit about what are the different use cases that this can be used on, right? From a disease specific, as we build these AI agents, what are the different use cases that we can look at? You know, for ventilated patients, looking at ventilator asynchrony to detect unsafe tidal volumes, readiness for spontaneous breathing trials. For delirium, we'd be interested in looking at restlessness. We'd be interested in looking at the level of sedation, looking at facial cues. For ARDS, we'd be interested in looking at proning and bundle adherence. For pressure ulcers, you want to and prevention of pressure ulcers, pressure sores. You want to track position, you want to track turning frequency. This is where AI moves from generic monitoring to clinical precision. Right. So, and you could ask me, if we already have ventilators integrated into EMRs, why add video? Because EMRs, while will record machine data, video records the patient experience, right? It'll show you effort, it'll show you asynchrony, it'll show you coughing, it can show you tube migration, it can show you the bedside interventions that were done, and it validates alarms, distinguishes real incidents from artifacts, and confirms compliance with protocols, right? So it actually can tell you what the patient is doing in real time. Uh, these are the different use cases, all the way from tracking SBT performance, what time a spontaneous breathing trial was done, what was the patient's breathing effort during a trial, to what time it concluded. VRAS for ventilated patients. This is Richmond Agitation and Sedation Score, but using a visual using visual cues to detect if a patient is agitated or a patient is heavily sedated. Delirium tracking, again, there are many folks working on delirium, looking at different cues, looking at things like emotion, looking at things like motion, looking at pose of patients to detect whether patient is in delirium or not. Ambient pain detection, I showed you an example of that in a previous video as well. And again, from bundle compliance, doing visual audits of bundle components to auto documentation. Uh, I want to, moving on, I think we have seen increasingly the rise of ambient documentation, where we've increasingly seen how tools that help us, the scribing tools that we've been using for a while now, have been helping us in our workflows and have been particularly helpful in the ambulatory and outpatient settings. In settings, in these ambulatory visits, there is a conversation between a doctor and a patient. And so the audio capture is highly effective and also less intrusive. However, when it comes to complex inpatient scenarios, um, you know, uh, I think video can document a lot more at this point in time, because a patient's in a bed for 24 hours a day. There are plenty of times when there is no conversation in the room, and yet there are things that are happening. And this is where the power of video AI comes in to help you with documentation. And it becomes more and more relevant and critical in the inpatient space. Um, all the way from, for nurses documentation, where we have flow sheets that need to be filled out for all the different things that nurses do, to some of the documentation tools, auto documenting when a spontaneous breathing trial was started to when it was ended, what the patient's position is at what time, how many hours a day was a patient in prone position, if they're an ARDS patient that's being prone, and more such examples. Uh, I think everyone would have heard about Dr. Atul Gawande and the Checklist Manifesto. Again, a seminal piece of work that led to the evolution of checklists. I think while checklists are great and have shown to be enormously helpful, especially when it comes to patient safety and helping us take care of our patients better, I think as care gets more complex, the fact of the matter remains that checklists are static, right? So they are static, and we are now have the intelligence and the power of AI to actually build agents for many of these checklists. And I think that we're at a point in time where we're going to evolve from a place where we're just using checklists to a place where we begin using agents, right? So agents don't just remind, but they actually monitor, detect, and prompt, right? So these are actually checklists that can see through using video, they can hear through your ambient scribing tools, and they can act, right? So they can actually either prompt you or give you a draft note and so on and so forth. So I think it's we're in the age of agents. Uh, and this was again something that was written by Eric Topol, Moritz, and group, which talked about how multiple AI agents can coordinate with one another. They had laid out a particular example, and this was in the context of a patient that had undergone surgery. And then you had multiple agents, right from a general practitioner agent to an agent that was looking at pathology, to an agent that was just monitoring the patient while they were inpatient, to a patient that was monitoring the skin wound. And in this loop, you had the colorectal surgeon that was getting all of this information from these agents to make sure that the patient got the care that they need. I think there are many corollaries that we can use for us in critical care, to build and to develop agentic care flow models. Right. So one particular example is, let's look at a 60-year-old male with ARDS, um, on non-invasive ventilation, right? You have video that can detect increased work of breathing through its detection of accessory muscle use, restlessness, and tachypnea. You have an agent that suggests relevant orders, imaging labs for a clinician review. The green boxes are where the clinician remains in the loop because the clinician is critical. This is something that, force multiplies the ability of the clinician and makes them far more effective, and helps us take better care of our patients. Right. So you have the agentic workflow here, where orders are placed after the physician has reviewed this. Then there is an agent that monitors for results, completion of these results, to see if they're done within time. If it's not, sending a reminder to see if these can be done and ensures that nothing is missed. And then you have an agent that reviews the results, um, drafts a note or an S-bar notification for a physician based on what the results are. All this while, I think it's key to realize one thing, that the clinician is still central to this entire process, right? So you see all those green boxes is the clinician in the loop. Right? So you have a clinician in the loop that reviews results, perhaps discusses this with their care team, maybe a nurse. You've got ambient documentation tools that can help you automatically create a note template, which can be reviewed by the clinician, who signs and final notes and pending orders are signed. And then you have this loop that goes on, essentially an agentic workflow that is building agents using scribing tools, using video AI, using analysis of data that's coming from labs, from EMRs, along with the input from video and along with audio input, creating a agentic workflow for clinicians. This is not very far. I think we are increasingly moving closer to this becoming a reality. There's a lot of work going on in creating a lot of these agents, and I think it's a really exciting time overall as we move in this direction. Uh, I think I want to now move on to what is the methodology for creating this clinical AI. I showed you a few videos, showed you the possibility of what agents could do, showed you potential clinical scenarios that video AI could be utilized in, right from delirium to pain to respiratory distress, potentially neurological conditions like seizures, etc. Right. So, but how is this clinical AI created, and what do we as clinicians need to know about, how to evaluate this? Right. So I think one of the things that is absolutely key is the clinician and technologist collaboration to define the problems and the safety needs here. I think without this collaborative approach, we're not going to get safe tools, and we're not going to get, frankly, we're not going to get tools that are perhaps very relevant, or things that we would need in our daily workflow, unless there is close collaboration between the clinician and the technologist. To train these models, you need expert annotation, right? You collect video data sets, similar to the paper that I talked about, where they had collected 140,000 hours of video from 8 ICU beds. And just to give you a sense, 140,000 hours sounds like a lot, but it's actually not, right? One patient bed would create close to 10,000 hours of video each year. right? So if you have 100 beds, you've got 100 times that, which is 1 million hours. So I think the thing that needs to happen here is you need, once you've collected these video data sets, you need expert annotation. So you need actual clinicians who can, the explainable AI that I showed you, who are actually going to look at patients and annotate those patients, that this is a patient with respiratory distress, or this is not. This is a patient with increased work of breathing, or this is an abnormal movement and this is not. Right. So that expert annotation is a key part of how the AI is created. You need to have large and diverse and high velocity data captured across settings, and across patients. Right. Again, this is key because angles are different. Sometimes bed colors are different. You have walls of your ICU room may be different often. So you need to have diverse settings that account for all of this diversity that we encounter in real life settings. You need control, but real deployment. So on the deployment front, you need staff champions, you need audit trails, but you need guardrails and safety measures before you can deploy any of these tools. And you need an iterative validation with live data to continue to refine accuracy and the impact on the workflow. Right? These are essential components of creating anything that is going to be clinically useful in the clinical context. Right? Now, coming to the part of how the models themselves are created, the machine learning or the AI methodology. This video data is collected, it's prepared, it's labeled, and then is divided in an 80-10-10 ratio, where 80% of the data is used for training, 10% for validation, and then 10% for testing. It's split in this manner. You have to train multiple model versions. So there are multiple models that can be built, and you have to select the best performers, right? And how do you evaluate whether a model is working the way that it should? There are F1 scores, there's precision, there's recall, there's accuracy, and there's calibration. But again, once you've tested these for these scores, then you need to test its robustness under real world video challenges and across patient groups. Let me give you an example of one such hurdle. There's a group that's been doing a fair amount of work on detecting delirium using video AI. And so they've collected several thousand hours of video. They've used expert annotators, nurses, and doctors to annotate them. They've then built these models to detect delirium. They've used three parameters to detect whether a patient is delirious or not. They're looking at the patient's emotion, they're looking at the patient's motion, the movements purposeful or not purposeful, and they're looking at the patient's pose, how they're lying in bed or how they're sitting, is it normal or abnormal? And while in theory they tested this and it worked well on the test subjects, when it was actually deployed in real world settings, one of the challenges that they came across was that they were not able to detect delirium in some of these patients, because they were not able to detect emotion, because especially in patients that had Botox injected into eyebrows. Right. So that became a big blocker. That was a real world blocker that they encountered, that, hey, you know what, patients have Botox. There are patients that have Botox that is inserted in their eyebrows, and that they do not look like other patients that would be having the same emotion. So this was a real world blocker. So this is where robustness of any model that you're deploying needs to be tested. And then, of course, even after you deploy, you need to continuously monitor, revalidate, and ensure governance around deployment of these models. So if you were to look at the sequence of events that need to happen, you collect the video data, then you clean this data, because there's a lot of raw data that you have. You need to clean it. You need to get the parts of interest. Then you get them annotated clinically by experts. Then you do the model training. And I told you, do the model training, and then you use 10% of it for validation. Then you do fine tuning on these models. And that at the end of that, once they are performing at a level that's acceptable, that's when you launch them in real world settings. And then again, you need to test their robustness in real world settings as well. I want to show you an example. This is some work that we have done in our group where we used video models to look at patient monitors. So these are bedside monitors, and pick up numbers and waveforms and detect them in, and automatically input them into an EMR, into any EMR. Right. So we looked at thousands and thousands of these models. Then eventually the model was trained to be able to look at any monitor, detect that, hey, if it's 99 and this is the waveform that's next to it, irrespective of what color it may be, that this is oxygen saturation and 99 is not the heart rate. Right. So, and to be able to make those distinctions. So this was how we created a model that would allow us to look at any screen of any monitor and be able to detect all the different parameters that were on that screen. And we saw the performance as we got more data, and we kept fine-tuning this model over a period of time. It took us some time before we were able to get to a 95% accuracy, right? So when we started in March 2023, we found that only 75% of the images that we were capturing and deploying the model on were actually accurate, where we were getting accurate numbers. And eventually, over a period of time and after continuous fine tuning, we were able to get to a point where we had over 95% accuracy of all the data coming through. So this is just one example, but again, of one model, but this is the same process that will need to be followed for any model that you are testing, are building, and are planning to deploy. I think I want to leave some time for questions. So I want to just close with this. So where does this really lead us, right? Towards an ICU that is autonomous in routine monitoring, is agentic in orchestrating workflows, and ambient in sensing continuously. I think that's directionally where the future of care is going to be. The goal again is not to replace clinicians, but to extend our vision, reduce burdens, and enable safer and more humane care. And with that, I'll I'll pause, and I'm happy to leave the next 15 minutes or so that we have open to questions. Thank you all again for having me here.
Thank you, Dr. Joshi. And what a fantastic overview of what is coming down the pike for us. I remember actually Neil Halpern's talk, because he came to this very forum to talk about his vision for 2050 and beyond. And I see that you're already there. So I'm not going to say very much right now. I just would like to open the floor for questions. So folks, just feel free to ask your questions. If you're a little shy, you can text it to me on the chat and I can ask it, or raise your hand and I can call out your name. Questions?
Hey, Dr. Joshi, a great talk, and truly appreciate it. So, as Dr. Gidwani just said, where do you see AI going in the immediate future and its applications? The three broad aspects, as in improving efficiency, or improving safety, or decreasing costs of care. I can understand both may be interrelated, but
Yeah.
where would you foresee the focused effort would be, in your view, for this to really take off?
Great question. Great question. And this is something that we ask ourselves since we do a lot of work in this space, right? And I think where I have if you ask me what is the there's a lot of technology that's being built, and it's moving very, very rapidly, this space, in terms of what can be done and the technology that can be built. I think the slowest part of the entire cycle is how do we build this into workflows? How do we actually get the doctors and nurses who are on the ground, who are used to a certain way of working, to begin adopting these tools, right? And when I view it from that standpoint, I think the two biggest factors for that would enable adoption faster would be patient safety and helping reduce documentation burden, right? So if you were to ask me, these would be the two places that I see the immediate use cases, because I see these are the two places where you will have the fastest adoption of the tools that we are building, right? And I think this is again, having spoken to lots of nurses and lots of doctors across a lot of hospital systems, I feel like the slowest part of this transformative journey is going to be the adoption curve, right? And in that adoption curve, we need to be solving real problems for the users, right? So that's the part that I see will happen the quickest and the fastest. Certainly, I think from reducing cost of delivery, when you look at administrative functions, etc., there's enormous amounts of work that's happening there in the AI space. Whether it is revenue cycle management, so on and so forth. But I think in the clinical delivery sphere, I think it's going to be patient safety and wherever we can help with documentation for caregivers. I think that's the space where we'll see changes happening in the immediate future.
Thank you.
While folks figure out what they want to ask next, I see. So first of all, congratulations on the very clever name, Aina. For those who may not understand the language in Hindi, it means mirror or holding up a mirror to oneself. So it expands on the visual LLM simile. So you have three centers, Bangalore, Singapore, and the US. Which hospitals have actually deployed this in which country?
We're very early in the phase of this. We use this extensively. So to give you a sense, we have this deployed in about 250 hospitals across India, right? And a large part of our training data has come from these hospitals. That's where we've been able to generate. We generate close to about 15,000 hours of video every day, right? So this is across several hundred patient beds, and that's really what's allowed us to accelerate and build some of these models. We're early in our journey in the US. We do have some ongoing pilots. The first one is actually just getting started at the Mayo Clinic down in Jacksonville, where they have already installed video cameras in their inpatient rooms, right? And so again, I I think I want to focus this particular talk more on where where I'm talking not so much about hardware. You can have any hardware, you can have any camera, but really about, how do you build disease-specific models, irrespective of what camera you may have, right? Once you've got the video input, how can you build these disease-specific models? So, uh, Dr. Kidwani, we're early in our journey, but I think a lot of work to be done and a lot of promise and a lot of potential.
Yeah, I mean, there are at least two, and of course more, large telemedicine companies by now. And are you looking to replace them or collaborate with them, or how do you see this deploying out? Obviously, or not obviously, I'm assuming you got some of this inspiration from your work as a telephysician in ICUs across the world. Yeah.
Yeah, a lot of my inspiration came from there. And we are not uh, replacing them, we are augmenting these companies, right? So again, our goal as an organization has been to build disease-specific intelligent models. Wherever you have a video feed, can we actually add intelligence? So essentially uh, think of there are three ways in which care happens, right? First, you sense it, then you think about it, and then you act. And we're really the thinking layer. So you can sense it using a video camera. You can act on it with a physician that's going to eventually put in an order or write a note. So we are neither one of those two. We are essentially just the thinking part, saying that if a video input comes in, what does this mean, right? What does this mean? What can we pick up? How can we help the person who is acting, right? The person who is acting is going to be a physician or going to be a nurse. And that is not a person that we are going to replace. We are going to augment that person by just helping them get more insight than they previously would have. Right. So our goal here is not to replace telemedicine companies or hardware camera providers, but rather to augment them and augment clinicians who are eventually providing care to patients.
Yeah, I mean, I don't look, I don't want to monopolize this Q&A. Please, I encourage people to ask questions.
So, in New York, we are, as you know, we are always struggling for beds. We have started recently hospital at home, HAH,
Yeah.
where otherwise patients are stable. They can essentially be sent home and they will have X amount of services provided.
Mm-hmm.
And something like this, where you're capturing videos in patient's home environment only when the patient turns it on, as in when
Yeah.
he's sleeping or whatever. And that would probably augment ability to uh, uh, address issues coming up, especially if there is a SVT, AFib, or something like that. And that's for our practice. We see that maybe an immediate use of an emerging technology to improve and augment or also assist. One, and complex patients, when they're discharged home, their readmission rates are pretty high. And if we have a service that a person can log in, download, and have through their mobile phone or whatever wearable device that can monitor for X amount of variables, disease state specific variables that they're already capturing, that can be integrated into the cloud platform and alert the physician as a biometric monitoring device. More, those, I don't know why I feel in my practice that would be an immediate need. And we tend to encounter several situations of readmissions or near misses many a times.
Yeah.
I would like to
I
hear
think
your
the
comments on that.
I I I think the use cases for this are innumerable, right? You will find use cases endless, galore, and I think it comes down to what your biggest problem and what is the use case that you want to solve. Again, think of this as a tool, right? This is really a tool that can be used to solve the problem that you have, the use case. Like you mentioned a use case, which is patients at home, complex patients at home that need monitoring. That there are others that mention that, hey, we have the same problem in hospital, right? So we end up having patients developing pressure ulcers. So we want to know, when they were turned, if they were turned, were they turned appropriately or not, or we want to detect if the patients at a risk for a fall, if they've pulled down the handrails and they're agitated and there's no one else in the room. Right? These are, I'm just giving you a couple of use cases. There are use cases where people want to detect delirium and want to detect the level of sedation. Is the patient too over sedated while they're on the ventilator? They've not moved at all. So can you send an alert to a clinician or to a nurse saying that, hey, this patient is appears to be highly sedated and may need to look at you may need to look at what sedatives they're on, or they appear to be highly agitated and perhaps they are at risk of dislodging a tube or so on and so forth. So I think these are just examples that I've given you, but these are the different use cases that exist, and I 100% with you. I mean, if that is particularly a strong use case where you are seeing complex patients that are at the safety risk when they are discharged home, leading to readmissions or either to some patient safety events at home as well, that's a very powerful use case.
You know, you're right. There are innumerable use cases. Sorry, Harish, go ahead.
So do you foresee biometric data integrating into the video capture that your company is doing and creating a definitive model that would be customizable for that particular scenario?
Yes. Firstly, to the first part of your statement, 100% yes. I think view, video as an additional feature, not as a feature that replaces anything else, but just gives you more insight. When you combine it with, other data that you're getting from, whether it is from devices or whether it is a patient's history, etc., the combination of those actually creates a multimodal inferential data set, which becomes much more powerful, right? So that's
Powerful.
the future. That is definitely the future, is where you are going to have multimodal inference that is happening. You have data coming from different sources. One of the very powerful sources is going to be video because, like I mentioned, it's actually a very rich medium, right? There are lots of things that devices and EMRs give you but that video can give you a lot more of, right? A lot more contextual.
May I ask a question?
Of course.
Paul,
Hi, thank you so much for giving this talk. My name is Pranay. One of the things that I think is, expected is a certain covenant of less privacy when someone is in an inpatient setting, right? Like, they don't have a lock on their door, people come and see them, but I guess part of that is that everyone there is physically involved in their care. Somehow it seems a little bit different when there's like a video that is stored potentially on like a cloud, being run on a VM somewhere, of people with like their face and body exposed in maybe, like the worst day of their lives, right? But at the same time, this is super useful. So we have to navigate this somehow. So how do we, what is the approach or what are the ways to deal with this?
That is a real world issue and a very important one, right? So firstly, there has to be a very robust consent framework to the application of any of these technologies that we're talking about. Secondly, there has to be a very, very robust sort of data protection framework and privacy protection framework. There are different ways in which it can be done. One is, of course, to not store data at all, right? Where you don't actually store data, you just use it for inference, or you store it for a minimal amount of time and then you delete it, right? And there
I
are
like
several, sorry, so that's one way of doing it. There are actually, interestingly, there are AI models that automatically can now be trained to, like, especially when it comes to, privacy issues and like worst day of your life, you're a patient in a room, perhaps you're exposed, etc. There are AI models that can actually blur and not parts of the frame itself, right? Such that certain parts. So there are different ways in which this issue, which is a very real issue, can be dealt with. One is just to use the AI model itself to blur out parts that you want protected and that you don't want stored. The other is to have a very strong framework for uh, storage of data, including how long you store it, who has access to it, so on and so forth. So I think these are some of the ways in which you address the particular issue that you talked about, Pranay, but a very, very real issue. And there are, again, from example, I'm telling you, there are different systems that are addressing it differently. I know some systems will not store data. I know some systems will store it, but only till the time of discharge. Some store it for 30 days post-discharge. Some store it for a longer period of time. Some of them are actively working on including models which will blur out parts that they don't want revealed. And of course, all of this comes with, a patient education and a very robust consent framework.
Thank you.
Thank you so much, Dr. Josie. That was great.
Well, again, thank you all for inviting me. This was an absolute pleasure and an honor. And I hope that everyone found this useful to some extent.
Thank you. Have a great day.
Thank you.